Thank you so much for joining us today for this discussion on the impact of obesity on psoriatic arthritis and how treatment approaches, including GLP-1 receptor agonists, might play a role in patient care. I'm Jenny Dunn, Director of Marketing here at ANRF, and I will be your host for today's session. We have a great lineup ahead. We have expert researcher, clinician, and a patient prospectus to really give us a well-rounded understanding of how all these factors come together in real-world practice. Before we dive in, I have just a couple of housekeeping notes. Today's webinar is being recorded. It'll be available on the ANRF website in the coming weeks. And we would love to hear from you. Please submit any questions you have in the Q&A box that you can see. We'll dedicate time at the end of the webinar to answer as many of those as possible. Okay, before we begin, I'd love to take a moment to thank our sponsors at Lilly for making this program possible. Their support allows us to bring you these discussions and continue advancing education in rheumatology patient care. So now let me introduce our presenters. We have with us today Dr. Heather Faust, who is a former ANRF scholar from 2022 to 2024. She completed her PhD at Johns Hopkins University and is currently a postdoctoral fellow at Brigham and Women's Hospital. We have Dr. Catherine Bakewell, who trained at the University of Washington for medical school, completed her residency in internal medicine, and went on to a rheumatology fellowship. She currently practices at Intermountain Healthcare in Salt Lake City, Utah. And then we have Jason with us today, who's living with psoriatic arthritis, and we can't wait to have him share his firsthand experience to help us better understand the real-world impact of these kind of treatment decisions. Today's session is a really unique opportunity to hear from a researcher, a clinician, and a patient, three perspectives that we know are key to improving clinical outcomes and patient well-being. Okay, I'd like to start with a knowledge check poll. If you all would take a look at this and vote for us, have you found weight loss therapies to be effective additions to a psoriatic arthritis management plan? If you can go ahead and let us know in the poll, everyone go ahead and click in, give us your answers. I'm seeing a little bit of both. I have not yet incorporated these treatment plans, and yes to both. Okay, so that's really interesting. I'm going to end the poll here. We're going to check back in at the end of this session to see what we've learned and how we're feeling. Okay. So let's jump into our presentations. First, I'd love to hand it off to Dr. Heather Faust. Dr. Faust will walk us through the latest research on how obesity exacerbates the symptoms of PSA. Dr. Faust, over to you.
Great. Thank you, Jenny. I'm glad to be here today to talk to you about generally about the impact of obesity on psoriatic arthritis. And as Jenny said, I'm Dr. Heather Faust. I'm currently at the Brigham and Women's Hospital. And just a fun drawing here I did in high school, a series of images of bones, and little did I know that I would be studying knee joints in my future. So I just want to start by acknowledging that psoriatic arthritis is a multifaceted disease. Patients have swollen toes and fingers, as well as skin and nail presentations as well. But today we're going to really be focusing just on the joints and joint swelling and inflammation and how it's linked with obesity. So first, a little brief background of psoriatic arthritis in the molecular mechanisms. Basically, I'm going to be talking a little bit about rheumatoid arthritis as well, because it's similar to psoriatic arthritis. These are both autoimmune diseases that attack the joints. They both have a lot of similarities, including synovial inflammation, bone erosion, bone remodeling, including bony spurs. Specific to psoriatic arthritis, the entheses, where tendons are inserted, are also inflamed. But in both diseases, autoimmune CD4 and CD8 T cells are heavily involved in this synovial inflammation, as you'll see in the diagram here. And importantly, TNF and IL-6 are involved in both diseases. More specific to psoriatic arthritis, IL-17 and IL-23 are heavily involved, which promote Th1 and Th17 CD4 polarization. And I'm going to come back to this in a couple slides. I just wanted to note that those types of T cells are heavily involved in psoriatic arthritis. These cytokines kind of in general activate fibroblasts to secrete matrix metalloproteinases that end up degrading cartilage. And currently, there are anti-TNF, IL-23, and IL-17 treatments available for psoriatic arthritis. However, not everyone responds, and they're not geared towards treating people with obesity. And as we know, obesity exacerbates psoriatic arthritis and rheumatoid arthritis symptoms and disease outcomes. So I wanted to show for you all some histology on the right here. The top two images are from lean patients with rheumatoid arthritis, and the bottom two are from obese patients. And the stain on the left is for CD3 T cells, and the stain on the right is for CD20 positive B cells. And so I think you can appreciate the inflammation and aggregation of T cells really gets worse in obesity. And obese people also attain lower rates of remission, roughly half the level of remission compared to non-obese subjects. And despite these strong clinical associations, no therapeutics exist to specifically reduce arthritis in obese patients. And so what are the possible biological mechanisms linking obesity to arthritis? One that I want to talk about is inflammation. And we're going to go more in depth about what exactly that means, because there's all sorts of different mechanisms for inflammation. But I want to talk about the visceral adipose tissue. And so that's the adipose tissue that kind of blankets your organs and is more inflammatory compared to subcutaneous or brown adipose tissue, which may even some different adipose depots have different functions. So we're talking specifically about visceral adipose tissue here. And in this tissue, obesity leads to adipocyte hypertrophy and rupture. And this causes all of the toxic free fatty acids to spill out of the cells. And this results in influx of inflammatory CD8 T cells into the adipose tissue. And then they can go ahead and they can recruit other immune cells like M1 macrophages, PDCs, and other pro-inflammatory mediators are generated, including interferon gamma, TNF, IL-17. And the visceral adipose tissue then releases some systemic mediators of inflammation, including adipokines. I've listed a few here. You've all probably heard of leptin, though. This is increased in obesity. And leptin can actually increase the polarization of CD4 T cells to Th1 and Th17. So just as I mentioned, those T cell subsets are very involved in psoriatic arthritis inflammation. Those are promoted by leptin systemic secretion. And so that's talking, within the visceral adipose cavity. But let's talk a little bit about outside of the visceral adipose tissue. Other general effects of obesity is that it strongly leads to type 2 diabetes and insulin resistance. And so this dysregulation of insulin, can help lead to immune dysfunction. So insulin can activate macrophages to secrete pro-inflammatory cytokines, as well as activate T cells. Now, if we go to the middle schematic here with the stomach, most people who are obese have adopted high-fat diet, quote, Western diets, which tend to increase the permeability of the intestinal barrier. This results in altered composition of microbes in the gut, as well as increased entry of LPS-bearing bacterial species, which can lead to systemic inflammation. And then on the right here, there is some evidence that these systemic immune changes increase arthritis severity. So there is a study done in fat-free mice, which show that fat-free mice are protected from arthritis. And this study went on to show that this effect was specific for the adipokine called adipsin. And there's further evidence that prebiotic supplements can help potentially reverse the effects of high-fat diet on gut microbes, and that they may be cartilage protective. Um, Although this is not to rule out other mechanisms by which obesity is linking to worsened arthritis outcomes. Um, and I wanted to take a couple slides just to talk about my work that's new and helps add some additional insight into this story. So I specifically look at CD8 T cells in arthritis. These are immune cells involved in adaptive immunity, and they've been shown to be involved in arthritis pathogenesis. They can secrete pro-inflammatory cytokines, and they can be cytotoxic depending on what specifically has been activating them, if they're at rest or highly activated. So one thing that we decided to do was take obese mice and isolate their T cells, their CD8 T cells from their adipose tissue. And we see that in obese mice, they have enriched interferon gamma and alpha pathway activation. So then we said, okay, if we inject exogenous interferon alpha, beta, which are both type 1 interferons, or gamma, which is a type 2, what happens? Do we see a difference in the CD8 T cell numbers? And we do find that type 1 interferons are able to increase CD8 T cell expansion in adipose tissue. And so what we next did was ask, is this relevant for arthritis? And indeed, we do see that IFNAR1 signaling, which is IFNAR1 is the receptor by which type 1 interferon signal through, exacerbates inflammatory arthritis. So I just want to take you through this graph on the left quickly. In the red line here, we have high-fat diet mice. They've been on high-fat diet for 8 weeks prior to initiating antigen-induced arthritis, and they're CD4 Cre negative IFNAR1 flox mice. So they have intact IFNAR1 signaling. The blue line is mice on high-fat diet, which are Cre positive, and these have IFNAR1 floxed out of all of their T cells. So they have no IFNAR1 signaling in the T cell compartment in CD4 or CD8 T cells. And the black line is lean mice. So I think you can appreciate here the high fat diet mice have worsened joint swelling, and this is reduced pretty much back to lean levels with the deletion of IFNAR1 in the T cells. And you can also see on the right here that there's fewer cytokine secreting CD8 T cells in the synovium, as well as F480 macrophages. And this work is currently under revision at JEM. And I think an important question that we all think about is what happens when you go back to a lean diet? Do things go back to normal? Well, we took these mice that had been on high-fat diet for 8 weeks, took them off of high-fat diet for 2 weeks, and we do see in the adipose tissue that the level of type 1 interference comes down very quickly. However, when we look at the adipose T cell numbers, it seems like they take a little longer to come down. They are going in the right direction, but it does suggest that it takes a little longer to undo all of the immunological changes caused by high-fat diet. But what about in humans? So we see that human data also supports that weight loss reduces arthritis severity. So this was some nice work by Jeff Sparks showing that, and I apologize for the low quality. I could not find higher quality images of this, but at 6 months and 12 months and beyond post-bariatric surgery, there's a great reduction in BMI. And this is also correlated with a great decrease in RA disease activity. So this might lead one to ask, with all of the GLP-1 agonists going out right now, how are these going to affect arthritis? Well, I just wanted to briefly talk about the GLP-1 agonist. So, GLP-1 is glucagon-like peptide 1. It's released after eating, and it stimulates the pancreas to release insulin and inhibit glucagon secretion. And this lowers blood sugar and reduces appetite. This is how they act to help weight loss. And so the agonists mimic GLP-1 to help aid people lose weight. And so far, no research has been done to assess the effect of GLP-1 inhibitors on arthritis, but they do show promise to reduce obesity. And since we've seen in other studies that losing weight helps reduce arthritis severity, this shows great promise. And actually, Dr. Bakewell was very kind in pointing out to me that there was an ACR abstract recently showing that 5% weight loss with medications, including GLP-1 agonists, were associated with improved patient-reported arthritis outcomes. And so she is going to talk about that section more, and I would like to hand it off to her.
Wonderful. Thank you so much, Dr. Faust. Now that we've heard about what the research tells us, let's transition to the clinical side. I'm so pleased to introduce Dr. Catherine Bakewell, who will help us understand what treatment looks like for patients in these scenarios. Dr. Bakewell?
Thank you. And thank you for having me today. I really do feel this to be an important topic. And so hats off to all of you who are taking time out of your workday to join us. I just wanted to kind of dive in to say what guidance or recommendations do we have in existence already for our patients with arthritis. And so if we take a look, this is both from the ACR, NPF, which is the National Psoriasis Foundation, and GRAPPA, which is the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. And already we have some recommendations here. So first is we recommend weight loss for our patients who are overweight or obese with psoriatic arthritis, and we want to encourage the maintenance of a healthy weight to improve disease activity and to minimize disease impact. And so even though this truly is a new field, right? Certainly, this has been new in my practice just in the last year. We do already have guidance in place that this is something that we should be addressing for our patients. And when we think about weight loss, there are four pillars, if you will, of therapy for patients who suffer from obesity. And the first, of course, is diet and exercise. And I have a few slides I want to talk specifically about what we should be saying to our patients around diet and exercise. And it's one of those things that it's like, okay, well, that's good for everybody, right? There's no surprise there. The next pillar, psychological and behavioral intervention, is something that we don't necessarily naturally think of, but as you think about it more deeply, it makes a lot of intuitive sense. So this is things like stress reduction, sleep and time management, and even planning your next healthy snack. You've heard it said before, if you don't know where your next healthy snack or healthy meal is coming from, you're not going to eat it. You're going to eat what's there and what's available to you. So it's kind of talking to people about planning ahead, but also in some instances, things like cognitive behavioral therapy to help people work on their self-talk, their beliefs around food, their triggers to eat. And so that is another important pillar that truly can be implemented for any patient who has overweight. Pharmacological interventions, that third pillar, again, a lot of exciting innovation in this field and part of probably the reason why a lot of us are here. And last but not least, surgical intervention. And so as we move forward, I'm going to talk about when each pillar is indicated. So this slide comes from a colleague of mine, Dr. Elaine Husney, and it highlights work that was done by Dr. Alexis Ogdi and Leahy Ader. And this gets at that question that has been asked of all of us in our clinical practices many times. Doctor, what should I be eating or not eating? Should I be adhering to a specific diet? What about this anti-arthritis, sort of anti-inflammatory diet? What works, what doesn't? And what I love about the work that Drs. Ogdi and Ader have been doing is really taking an objective look at different diets and seeing what correlates with disease activity. And what you'll note here is that, unfortunately, of course, our Western diet, which is high in sugar and moderate in fats, does correlate with increased disease activity, whereas the only diet that appeared to have benefit above and beyond just weight loss and the weight loss effect on arthritis was the Mediterranean diet. Which, as you're all likely familiar, it's a fruit, vegetable, high plant-based diet, whole grains, maybe some white meat, a lot of fish, very little to no red meat. And so I do talk to patients about this, and you've probably also seen that there's data that shows that this has benefit in terms of Alzheimer's prevention, reduction of cardiovascular risk. So if I'm going to recommend a diet to patients, it's going to be this one. I will also say, and this is something that is coming up in Dr. Dr. Ogdi's work and something that, my patients, including Jason, who we're going to meet later, figured out on their own, which is that processed sugar itself does in fact increase that disease activity. So I think my patients educated me on that first, and then now finally Dr. Ogdi's giving us the data to back it up. But in one word, Mediterranean diet, some of these other diets like gluten-free, lactose-free, some patients that will be very beneficial for, but it's going to be the patients who are intolerant or even potentially allergic to those agents at baseline. It's not necessarily inherently something that all patients with arthritis need to be doing. So here, building off of what Dr. Faust showed us, which is that weight loss improves disease activity. So she showed us some work from Dr. Jeff Sparks. This is just with caloric restriction, and it's showing us across, so at baseline all the way out to month 6, different metrics of disease activity for patients with psoriatic arthritis. First, the body surface area, again, just a percentage, 1% being, the palm of the patient's hand of psoriasis involvement. DAPSA, that disease activity score in psoriatic arthritis, the DAS28-CRP, widely applied across psoriatic and rheumatoid arthritis, and then the HAQ, that health assessment questionnaire, disability index. And you can see across all of these metrics, the patients improve as they lose weight, again, this time just purely from caloric restriction. So what about exercise? What should we be saying? And does it even make a difference for us to recommend exercise to our patients? I think sometimes we feel crestfallen. We're not really sure how much we get through, to people to change lifestyle. It's hard to change lifestyle. We're all creatures of habit. But this is a statement from EULAR saying, and this is, I'll read you the little box. It says, exercise and physical activity promotion according to the public health recommendations is effective and should be an integral part of standard of care throughout the course of disease in people with rheumatoid arthritis, spondyloarthritis, and even hip and knee osteoarthritis. And what we're looking at is forest plots in terms of the doctor talked about exercise and did the patient actually change their behavior based upon this. And across all there is a strong trend, I should say, towards change in behavior. And it's tough, but it does make a difference. And I think that's kind of a call out to all of us to not get lackadaisical, right? And say, I don't have time to bring that up. We do and we should. So what should we be saying other than, I have these little silly kind of movement is medicine, motion is lotion, and I believe it. And it's memorable, but what specifically should we be telling people to do? Obviously, you have to tailor it to the individual. There are some people who may have increased risk for cardiovascular disease. You have to be careful with, don't tell them to just kind of, hit the gym running. They need to gradually increase it and make sure they don't develop angina, so forth and so on. But all other comorbidities notwithstanding, the recommendation for the Surgeon General is that you're going to get a minimum of 30 minutes of cardiovascular activity of moderate intensity 5 days a week. However, interestingly, you can shorten that. So if you're going to do vigorous intensity aerobic activity, you can do that for a minimum of 20 minutes on only 3 days a week, right? So everybody's kind of talking about this, the HIIT training, the high intensity interval training. And so there is more benefit the harder that people work out. And you can actually shorten the recommendation for how long they need to work out. You can combine moderate and vigorous intensity exercise. And if you can't find a 30-minute break in your day, and again, this is from the American College of Sports Medicine and the American Heart Association. They're saying, look, break it up. Do 3 10-minute intervals. You can do 10 minutes over lunch, before work, after work. You don't have to find that solid block of time. It still counts. Also, every adult should be doing weights at least 2 days a week. And this is kind of a funny last statement. It says, because of the dose-response relationship between physical activity and health, individuals who wish to further improve their fitness, reduce their risk of chronic diseases and disabilities, and or prevent unhealthy weight gain may benefit by exceeding the minimum recommended amounts of physical activity. I probably didn't need to read that to you or even tell it to you, but essentially, these are not caps. These are just minimums, right? So if people want to do more, there are additional health benefits to them from doing that. Dr. Faust touched on this, and I think it's a fascinating story. There are different kinds of fats, and I did not know that until I started to delve more deeply into this field. So when we think of fat or adipose tissue, most of us are thinking of white adipose tissue or visceral fat, as Dr. Faust was referring to. And these are the troublemakers, right? Because these are promoted by a high-fat diet, and they are pro-inflammatory. And they actually can promote, again, inflammation and potentiate that within our patients with inflammatory arthritis. Now, they can transdifferentiate into a beige adipocyte, which is more metabolically active, so higher mitochondrial count. And there's even a whole separate type called brown adipocytes, which is likely a separate lineage of pre-adipocytes, but you can cause hypertrophy or growth of these cells through things like exercise and cold temperatures. So we're all born with more of this as infants, and our stores tend to dwindle as we get older. But these are fat cells that actually burn fat. They burn the white fat cells, right? And reduce inflammation in the body. And the cold temperatures is fun. So you probably are familiar with the whole fascination around cold plunges or cryotherapy. And there is some data to support the use of cryotherapy to increase our brown fat supply. So of course, their exercise as well. And I asked an endocrinologist, what are beta-3 agonists? And she said, oh, listen, it's things like theophylline, and you would never take this for specifically this reason. What you're looking, if you really do want to increase your brown fat stores, is the cold temperatures and exercise. So on a more basic level, let's take a look at what is recommended to us from the American College of Cardiology, pardon me, and American Heart Association about how are we supposed to be managing our patients with obesity and or overweight. And so it stands to reason. So anybody who is overweight, so again, that's a BMI of 25 up to 30. Above 30 is considered an individual who's suffering from obesity. Anybody who has comorbidities who's in that group, you're going to be talking to them about diet, physical activity, behavioral therapy. And comorbidities are things that you would imagine them to be, right? Dyslipidemia, diabetes mellitus type 2, history of cardiovascular disease, obstructive sleep apnea, even hypertension. So anybody who may have a comorbidity from their obesity merits some intervention. Now, independent of the presence of comorbidities, we're going to be having this conversation for any individual who has a BMI over 30. Now, what surprised me about this chart is that anybody with a BMI of 27 with comorbidities up to 30, we're going to be having a conversation about pharmacotherapy. They are a candidate for medication to help with their weight. And again, regardless of comorbidities, they're a candidate for medication if their BMI is over 30. And then last but not least, the metabolic and bariatric surgery. Again, this is, permanent. We want to sort of save this to see if everything else has failed. This is our option. And this is going to be individuals with a BMI over 30 who have concomitant comorbidity. So again, for me, the eye opener was here. It was in that anti-obesity pharmacotherapy indicated BMI 27 to 30 with comorbidities or anybody with a BMI over 30. So what does it look like, right? So this is kind of like what is out there, what have we seen, what can we prescribe or refer to have patients consider with an endocrinologist, for example, or their primary care physician. Phentermine I had heard of for a long time, so this is technically scheduled medication from the FDA or DEA. It's Schedule 4. It is a noradrenaline releaser or norepinephrine. These are synonyms. And it has a stimulant type of effect on patients. It is indicated only for short-term use for weight management or weight loss, so up to 3 months with monthly visits. And you need to be watching people for high blood pressure, tachycardia, things that you would think of as stimulant effects, right? Now, when you mix it, interestingly, with the anticonvulsant topiramate, so phentermine plus topiramate is still controlled as a Schedule 4 medication, but it is indicated for chronic weight management. So you don't have to limit it to just the 3-month stint. And you may have seen this marketed under the brand name Qsymia. These other two also norepinephrine releasers, or three, I should say. When we get into bupropion plus naltrexone, marketed under the brand name Contrave, interesting because these are medications that we might otherwise use in rheumatology, right? So naltrexone, of course, is the opiate antagonist, but many patients have interest in it for it's been not FDA approved, nor will it be, but for reduction of pain and or inflammation in individuals with inflammatory disease and or fibromyalgia, the low dose naltrexone. But in this setting, when combined with bupropion, it promotes weight loss. Orlistat, also been around for a long time, over 10 years. This is a gastric and pancreatic lipase inhibitor. We're coming to it, but it inhibits the absorption of fat in the diet. And so, as you would imagine, what are the side effects? Well, oily stools, diarrhea, malabsorption. Nobody was a huge fan, but it works. And then enter the GLP-1 receptor agonists. So this has really been what has changed the landscape over the last couple of years, and why all of our patients are coming to us and asking us about this. So currently on the market, liraglutide, indicated for type 2 diabetes, also cardiovascular risk reduction in individuals with type 2 diabetes, semaglutide, another GLP-1 receptor agonist, but with an indication for weight loss, and tirzepatide, for diabetes mellitus and weight loss. It is the only one that is a combined GLP-1 and GIP receptor agonist. So GIP is glucose-dependent insulinotropic peptide. It's another member of the incretin family. Dr. Faust started to talk to us about this. So the incretins are here at the bottom of the slide, and essentially these are hormones. And incretin is a hormone that your body releases in response to eating. And so it's supposed to do everything that is a natural response to having eaten. So it'll increase insulin release and then increase satiety, decreasing appetite, delays gastric emptying, right? So you can kind of process your food. And so this is the way in which these medications work and promote weight loss. Nothing really surprising on the upper part of the slide. I will call out the biguanide. So here, metformin, far and away the most common agent in this class. We have seen here, so the sodium glucose cotransporter 2 inhibitor, also called the SGLT2 inhibitor. Interestingly, there is some data that it promotes, it's nephroprotective for individuals with lupus nephritis, for example, and even individuals with chronic renal insufficiency. I have seen nephrologists recommend some of these weight loss agents to protect the kidneys. So there's growing use of these agents over time. So here we're going to look at adverse effects and contraindications of each of the medications. We touched on these. I don't want to, in the interest of time, go into great detail, but you'll note that all of these medications have pregnancy as a contraindication. So we do not want to be using any of these agents in our pregnant patients. We just don't have sufficient data. What's interesting, though, and this is anecdotal just from my practice, I can tell you that I have had a number of patients over the years who were struggling with infertility, who had polycystic ovarian syndrome and all of the hormonal imbalance that confers. And it was actually either their fertility doctor or their OB who said, you know what? Why don't you go on a weight loss medication for a number of months, get your BMI down, and that will help to restore your hormonal milieu back to a more fertile state. And I have seen that work for some patients. So it's kind of ironic that even though we're saying, okay, not for our pregnant patients, and yet for some patients, I have seen it recommended to promote pregnancy down the line when they're off of the medication. So orlistat, we mentioned, diarrhea, loose stools, fat-soluble vitamin deficiency, things you want to pay attention to. Phentermine, topiramate, things like headache, dizziness, fatigue, nausea. Again, the Contrave, the naltrexone, bupropion combination. No real surprises there. Some patients suffered from insomnia. You do want to not use this in patients who either have a seizure disorder or uncontrolled hypertension. And now we get to the GLP-1 agonists. So mostly we're talking to our patients about GI side effects, and that's why you'll notice that there's a dose up titration. You start low, go slow, because diarrhea, nausea are fairly common adverse effects that can be experienced by patients. Starting these, you do need to warn them that because of the delayed gastric emptying, they need to let their anesthesiologist know that they're on these if they're going in for any kind of procedure, and they probably would need to hold their medication and or be NPO for longer before a procedure. And talking to patients, you do need to ask them, do you have a personal or family history of medullary thyroid cancer? Again, a family history of multiple endocrine neoplasia type 2 or MEN type 2, because specifically medullary thyroid cancer is included in that sort of constellation of endocrine neoplasms, including pheochromocytoma. And so this is very rare, but something you need to be careful about and ask your patients about. And we need to be recommending exercise to these folks too, because it's as we start to lose weight, sometimes we lose muscle as we lose fat as well. And so maintenance of weight-bearing exercise is very important. So here we're taking a look at the effect of these medications. This is first semaglutide, and on the x-axis is weeks. So we're out to 68 weeks for both of these, and you can see there's a significant difference between the semaglutide treated patients and those who are on placebo. The y-axis here, we're looking at a change from baseline in terms of percentage body weight. And for both of these, around a year, we're tending to max out, maybe some incremental benefit after that, and maxing out at around that, we'll say about 16% the body weight from baseline. Now we're looking at tirzepatide, again, reduction of body weight, looking at a couple different doses from 5 milligrams ranging up to 15 milligrams. And there is a dose response, but I mean, to my eye, 10 to 15 milligrams weekly looks fairly similar, all of them statistically differentiating from placebo. Here we're going to see this is kind of the news flash, right? So this is something that hasn't even shown up in publication yet. This was a news release by Lilly in December of 2024. They did run a head-to-head of tirzepatide with semaglutide, and they took patients to the maximum tolerated dose of both of these medications, and they were able to show a greater percentage body weight loss with the tirzepatide treated patients versus the semaglutide treated patients. And so kind of fun to see that again, both beneficial, and there's issues of kind of who has access to what medication, what's covered, can you get it? But we always love head-to-head data, right? When we can find that. So now liraglutide, again, indicated for our patients with type 2 diabetes. This is a look at how their psoriasis does when they're treated with liraglutide. And a couple of the confidence intervals crossing zero, but by and large, overall, significant improvement in the psoriasis in patients treated with liraglutide. And this is that slide that Dr. Faust was referencing in her discussion, which is an ACR abstract. So previously, we really didn't have any specific data that medications that promote weight loss improve arthritis outcomes. We had data that weight loss improves arthritis outcomes, and that patients with concomitant obesity had worse baseline arthritis and less of a response to our anti-arthritis medications. But to show specifically that weight loss medication and concomitant weight loss improves arthritis outcomes is really a new and growing field, and there are currently randomized controlled clinical trials that are enrolling. But what you're looking at here are patient-reported outcomes. So the most dramatic, I feel like, this is patients who could lose 5% of their body weight, and this was either medication or in some instances surgery, but there was a significant reduction in pain and global severity of their arthritis impact. And this was any rheumatic disease ranging from psoriatic arthritis, rheumatoid arthritis, even osteoarthritis. So taking kind of the bird's eye view, my take home for you is not, look, you need to start tomorrow prescribing all of these medications. You are not alone. Fortunately, we all exist within an ecosystem of healthcare, and we don't have to take this on, but just being aware of it and its impact on our patients, I think, is critical. And to think potentially about referring out, right? Do you want a specialized nurse within your own practice? Do you send to an endocrinologist? Do you want to send somebody back to their primary care to think more about this? And again, psychologists, all of these people, dietitians, nutritionists. I have an endocrinology friend who says, I have an exercise physiologist in our practice. And I'm like, that's amazing. I love that. It's better than PT, right? So the idea is, build your ecosystem for wellness for your patient, because they will benefit when we take that holistic approach. So in conclusion, I've thrown a lot at you here, but I want to make sure to hand it over to Jason in plenty of time. But my take homes for you are as follows. Obesity does significantly increase the risk of psoriatic arthritis. Obesity increases inflammation, disrupts the gut microbiome, just like Heather talked about, and puts additional stress on joints, all of which may contribute to worse outcomes in psoriatic arthritis and or the development of the disease. People with PSA and obesity do not respond as well to the treatment or are as likely to be in remission as those without obesity. And weight loss in people with psoriatic arthritis and obesity can significantly improve outcomes, right? So we've all had those patients where it's like we've tried a lot of different medications and we've just hit a wall. We're not able to get them better. And perhaps that missing piece for them is addressing the BMI over 30. So again, people with obesity and PSA should consider weight loss medications or potentially even bariatric surgery in addition to lifestyle changes to really get them to their goal. And with that, I'd like to wrap it up and hand it over.
Thank you so much, Dr. Bakewell. I'm sure it's been really fascinating to see these new treatment options emerge, and we are so fortunate today to hear directly from a patient who's worked with you and experienced these therapies firsthand. So, Jason, we would love to hear your journey. Can you share your experience with us?
Yeah, sure can. There we go. This is me, the first picture here. This is me before. This is my before picture, 380 pounds. Uh, and trying. I remember this picture was taken. We had a trip to Arches National Park about 7, 8 years ago. My companion felt it would be fun to go hiking. Me, not so much, but I didn't want to ruin her fun, so I gave it a good shot. I get the hiking poles. Got to not fall when you're 380 pounds. Falling at 380 pounds is bad. And so when we got there, I was able to do a couple hikes, but to me, a hike was maybe a 15, 20-minute walk, flat only. No, not going over rocks and stuff. That was just too painful for my knees and stuff. And then I would just use my binoculars to look around and take pictures while my companion would hike, do the real hiking, and I'd wait in the car and for them to get back. And I remember feeling like, hey, I'm trying hard. I got out there and I felt good about that. But I also remember feeling left out. I was not able to do the things that other people were doing all around me, and it kind of hurt. So a few years after this picture was taken, I had to have total knee replacement on both knees. My psoriatic arthritis and my weight had just done too much damage, too much permanent damage was done, and I got the knee replacement, and that helped a lot. I started getting psoriasis as the white scaly patches on my hands and elbows about 30 years ago. So I've been going through this a long time. It didn't hurt or keep me from doing what I wanted, so I just covered it and went on with my life. And then about 10 years after that, I started having the soreness in the joints, same joints with the patches, the psoriatic patches, and I mean, bad soreness. I mean, enough to where I begged my doctor and he referred me to a rheumatologist who diagnosed me with hardening of the tendon ends back then. I recently checked out the www.curearthritis.org website, downloaded one of their fact sheets, and it listed hardening of the tendon ends as a symptom of psoriatic arthritis. I did not know that at the time. But back then, 20 years ago, you had two different conditions. You had psoriasis and you had arthritis, requiring two different doctors prescribing two different treatments. I tried the various creams, ointments for the white scaly patches of my hands and elbows. I tried UV therapy. It was experimental back then, but I tried that. And I've been prescribed NSAIDs, aminosalicylates, antisporatics, pain medications. I've had cortisone shots. I've even tried the expensive biologicals. Some of the medications worked better than others, but eventually they just did not do a good job at reducing my pain and joint damage. About 15 years ago, I was lucky enough to get picked up by rheumatologist Dr. Catherine Bakewell. Dr. Bakewell was the first one to start treating me for one condition, psoriatic arthritis. And since following the recommendations of Dr. Bakewell's medications, uh, my white scaly patches have decreased by 95%, and the pain in my joints has decreased enough to keep working, which is the most important thing to me is to stay working. About 6 months ago, I started having problems with pain in my hips and lower back, and it was getting worse to the point I'm missing time off because of the pain. Uh, my rheumatologist suggested that I could try a GLP-1 formulation to help get my weight loss started again. I seem to have gotten stuck about 345. I lost down from 380 to about 345, but then I just plateaued there. And she thought that it would help me get uh, the weight loss going again. And she said that the overall weight loss will get the weight off my hips and joints, and that may reduce pain and help prevent further permanent joint damage. So I tried the GLP-1 medication that she prescribed for me, and I've only been using the GLP-1 for about 4 months now, but I've lost 10% of my body weight already. So I've lost 40 pounds, and I'm now down to 302 pounds and still losing. I'm getting very close to my first goal of being under 300 pounds. I've been there for a long time. I'm feeling less pain in my hips, and I noticed that I'm beginning to stand up straighter. And since using the GLP-1, I now feel full while eating. Before I would feel full, or by the time I felt full, I'd way overeating, and now I feel full while eating, and I'm able to stop eating, dude, because I'm full. And I notice that my skin is clearing up. I have almost zero white scaly patches on my skin now. So the physical psoriasis is almost 100% gone. Losing weight has helped me to keep working. I've not missed a day at my job due to a bad flare up for a while now. So I still have flare ups, but they are less painful than before. One thing I did not expect from the GLP-1 was and losing the weight was that my mental health would improve so much. I'm feeling less stressed. I'm calmer. I'm more confident. I'm not relying solely on the GLP-1 alone. I'm trying to eat healthier, uh, although it has helped me with the cravings of soda, fries, chips, and over processed foods. It's a big change to keep away from those foods. I'm changing from junk food, fast food, and packaged food to eating whole food. My food shopping has changed from prepackaged frozen food aisle, things you can make quick. Standing and cooking was just too painful to stand and try to cook. But now I actually cooked the other day and it was nice. So my eating habits are slowly changing. I now crave nuts, fruits for a snack, and I don't keep the over processed junk food in my house anymore. I just don't buy it. I don't have it. I don't need it, and I hardly ever crave it now. So this last picture it's me is I'm now 302 pounds, still a lot of weight loss to go. But I chose to be in my work uniform for this picture for a reason because I'm hoping to work full retirement age. Something I thought I would never be able to do is just to make it to retirement. And continuing to work closely with my rheumatologist and following the prescribed psoriatic arthritis treatments and advice are key to reducing my joint pain and preventing further damage to my joints. This will help me stay working full time and reach my goal of just retiring and having a better life. So that's all I have. So thank you so much.
Jason, thank you so much for sharing that. It's really powerful to see how these treatments translate into real world impact. And I'm so grateful you're here. Everyone, we're going to move into our Q&A section now. So if you have questions, please put them in the Q&A box. We'll try to get through as many as we can in about 10 minutes. I think what we will do to start off is just, I've got one ready, which is, what are the key clinical signs that indicate obesity is exacerbating PSA symptoms? So I think Dr. Bakewell, this one is a great one for you to start with.
Yes, and I do want to say, Jason, thank you so much for getting up and sharing your story with everybody. And I hope everyone hears how much this is, yes, the medication is wonderful, but I wish all of my patients would do what Jason did, which is also really diving into health and wellness and focusing on their diet. And it really starts a cycle of wellness, right? When you start to get gains and you start to have that confidence and it boosts your mood, and you're like, you know what, I really do feel worse when I eat the processed sugars. And like I said, you figured that out before we had data, to say that that was, so hats off to you. I think that's phenomenal. So I just wanted to start with that. But actually, Jason's story is classic too, in a sense that people who suffer with obesity who are also having a lot of pain in their weight-bearing joints, like the knees and the hips and the back. So that's kind of the mechanical side of it. And Jason shared that he had had his knees replaced and was having a lot of troublesome hip and back pain that is now much better as he shed some of the weight. And so just getting that weight off of those joints, I think people don't realize sometimes that you can carry up to 4 to 6 times your body weight in your knees and your Achilles going up and down stairs and off of curbs. So it's a little bit of weight makes a really big difference in terms of the pain and the load on your weight bearing joints. But that's not even getting into the inflammatory side of things. I think I just kind of touched on the patient who has tried multiple medications over the years, and we've just never quite gotten them into remission with their inflammatory disease. And if they do have concomitant obesity, that's a great place to start, right? Is to start the conversation and say, I wonder if this could be contributing to some of your disease activity, and how would you feel about exploring this as a therapeutic option?
Hmm. Was there a turning point in your discussions together that made you feel ready to address weight as part of your treatment plan? And that's really for both you, Jason and Catherine.
Well, the weight was always a part of it. You got to know when you weigh 380 or 340, that's you got to weight loss for up, So, but I had plateaued is the thing. I lost on my own from 380 to about 345, a little bit less, but it went back up a few pounds, and I just plateaued, and that didn't seem like anything else I was doing was working.
Mhm.
I'm still craving fast food, junk food a lot. And you turn to that because it's easier to cook. You don't have to stand. It's just makes you feel good. But that plateau is what Dr. Bakewell recommended, that maybe let's try this and see if we can get the weight loss started again, and drop some more weight. And it has worked. I've dropped down to 302. I'm looking at being under 300 soon, and it did get me off that plateau, and that's really what I needed, because every pound I lose, I just feel better. Like I said, I've got a lot of good things that are happening, and I'm working. I'm going to work every day, and I feel, well, full time, and that's what the main thing is. I got to be able to work and support myself. That's the most important.
Yeah, that makes sense. Thank you. Dr. Faust, can we just ask, so, your research really highlights the inflammatory connection between obesity and arthritis. What surprised you the most in your findings?
Yeah, that's a great question. And first, I just an offhand comment. I didn't really emphasize that the obesity not only um, increases the susceptibility of the weight bearing joints like knees and hips to get worse arthritis, but also like the finger joints, the little joints like that aren't even weight bearing, have increased arthritis susceptibility with obesity as well, which is part of the reason why we wanted to look at the immune side of things, because it was clear to us that it's not just weight bearing itself that's increasing the susceptibility. But to your question, I was really surprised to find that interferon type 1 signaling was increased in these obese mice, and we actually did look at a human data set where you see that CD8 T cells do have increased interferon type 1 signaling activated in T cells. And it was surprising because other studies of arthritis severity haven't necessarily correlated, at least in mice, with or without interferon type 1. But I think in the obese context, which kind of has been understudied in arthritis, it does seem that interferon type 1 is a negative impact on arthritis severity. So that was very surprising to me.
Yeah. I'll say to those watching, if you're curious about more of Dr. Faust's work, look her up. You can always find her on curearthritis.org. I think we only have time for one more question, and I'm going to go with this one. They asked Jason, after you started the GLP-1 agonist, how long did it take for you to start to notice relief in your joints? Was it quick, or did you really start to notice a change when the weight decreased more significantly?
Well, yeah, I've only been taking it for 4 months now,
Mhm.
so I would say that was quick compared to some of the other stuff. Is like, well, in a year or two, you might feel a little bit better. So it was pretty quick. I started losing weight really fast at first. It slowed down just a little bit, but every pound off seems to just feel better. I'm moving better. I'm bending better. And I'm more active. I'm not up to where I'm just going to the gym or anything yet, but it's coming. And but I am doing my regular chores at home. Before I couldn't even get my chores done at home because I just hurt too much. I couldn't even, my house is dirty, but now I'm getting my stuff done at home and doing little projects like I like to do, and it's coming. It's every pound off seems to help. So
It sounds like a lifestyle improvement pretty quickly, really.
definitely,
Yeah.
yes.
Yeah. Well, thank you so much for those questions. I really appreciate that, everyone. Before we wrap up, I'd like to do another quick knowledge check. So I am going to share our knowledge check number 2. If you guys would go ahead and answer this, our little poll here, how likely are you to incorporate weight management strategies into your PSA discussions with patients? I'd love to hear this. And really quickly, it's coming in quite quickly that we are very likely. Yeah, I mean, I think from what we've heard here today, what incredible results we're seeing. And we're so grateful to our panelists for having that discussion with us. I want to say a huge thank you to those panelists, to those presenters, Dr. Faust, Dr. Bakewell, Jason. Thank you so much for sharing these insights, sharing your expertise. And of course, a very special thank you to Lily for making this programming possible. Before we wrap up, I want to share just a couple important resources. In the coming weeks, we're going to be releasing a patient guide to just really help navigate these conversations in the clinic. It'll be available on our website, curearthritis.org, alongside our many fact sheets, our guides. Thank you for plugging those, Jason. That was beautiful. Many of those are also available in Spanish if you didn't know. So if you're looking for patient resources, please do guide them there. And then finally, we're hosting a patient-facing version of this webinar next Thursday at 12 Pacific, 3 Eastern. This will really focus on what it looks like from a patient's perspective. So if you know anyone who might benefit, please feel free to share these details with them. Thank you so much for joining us today. Until next time, take care.